Now we have Dr. Shweta Tripathi from Lucknow, from it is not Rajiv, it is Indira Gandhi Memorial Hospital. Okay, it is Indira Gandhi Memorial Hospital. She is the director of glaucoma services over there. She's going to talk on gonioscopy and UBM for angle evaluation. Over to you, Shweta.
Thank you, sir. Thank you, sir, and thank you, AIOS, for giving me this opportunity. So, when we talk about gonioscopy, I'll start with the sentence that this is the best friend in a glaucoma clinic, and I'll conclude my presentation with the same thing, it's a best friend in a glaucoma clinic. So when we talk about gonioscopy, let's answer a single question, that why do we do this, gonioscopy or UBM? The answer comes immediately that we need to evaluate the angle. Now, why this evaluation of angle is important? Because you need to make a diagnosis correctly to treat a case. Until unless you make a correct diagnosis, you will land up adding the AGMs on the patient's eye, compromising the quality of life, and second, you're not going to achieve the target IOP, which was dealt in the last lecture. Because what will happen when the angles are not open, no matter whatever you do, the pressures are not going to get controlled and your patient is going to get progressed. So now the gonioscopy helps us to evaluate the angle, give us a treatment protocol after making the diagnosis, and for the prognosis of glaucoma, and these are the two means through which we evaluate the angle. The picture on the left side is, everybody knows, it's a gonioscopy being done, and the right side, it's a UBM being done. So before we go in the clinical part, let's have a look over the history. Could be there as a viva question for you, that who was the first person to coin the term gonioscopy? And Trantas is the answer, although Salzman was supposed to be known as the father of gonioscopy. And when we come for the UBM, this was the technique which revolutionized the field of angle evaluation, because after that there was no looking back. It was conceptualized and started in 1990. And then we could have there is a difference between an angle assessment. There's a subjective assessment and objective. So let's understand the difference between two. Subjective is like if person A sees something, person B might not see that thing, and person C might see a thing different. That's subject, sabka alag alag hoega. But for the objective method, there is a clear-cut calculation. So here, this UBM got an edge over a gonioscopy. It gives us the objective assessment, and the core concept was lying only in the oscillating probe of this transducer, which oscillates between 35 to 50 megahertz, sometimes goes up to 100 as well. And this resolution or this frequency gives us the ideal balance of resolution, depth penetration, for seeing the structures. Because when you're visualizing any structure, it has to go to see that which structure you want to see and what is the resolution, what is the magnification of that particular structure that you want to detect any pathology in that. So to note it, you can say that it has got a depth penetration of 5 to 7 millimeters, lateral resolution of 50 microns, and an axial resolution up to 25 microns. So now this is what I was talking about. If you see this, this gives a objective assessment to us. Here, you can see the angle opening distances, you can see the TIA 1, 2, all these things can be measured with UBM, which cannot be done with a gonioscopy, but always it is a but. So before we go for that but, let's have a look over this gonioscopy technique, that this is how you're supposed to do in your clinics. Put the gonioscope, put the gonio gel, remove any bubbles. There should be no bubble. Now, place the patient correctly with the chin and headrest there. See the light. It's there on the nasal bridge. And still, you ask the patient to look up. Switch off the room light. And there you put the gonioscope. And now you gradually bring the light from the nasal side towards the eye. Now you align your slit lamp, and this is how you visualize your structures of the eye. Now taking out is also really important, because in literature it's described as an optic nerve avulsion has been happened. So ask your patient to squeeze the eye, and then you take out the gonioscope. So with that we go, this was like the patient was sitting comfortably in the OPD. Now this one comes with a a supine position, as we know, because it uses, earlier when it was launched, it was using a water bath technique, and the transducer was going in that water bath, and it used to be quite cumbersome. But yes, as the technology evolved, it came out with the help of this is a transient window changing technique, and the other one is a sterile balloon method. Here what it is done is that water is filled into this chamber, and this is placed on a probe like this, watertight closure, and then you place it over the eye, and there you do it. So the technique of doing it is little more friendly, and the patient is going to cooperate with you, and it can be done in a semi-reclining position as well. Now, this is the most important part of your presentation today. That's a scan orientation. Because here, when we go back at this picture, you see there is a white mark. Can you see this white mark? So this white mark is going to decide as to which area you are going to subject your patient for the analysis. So now here what you do is that the probe is placed directly of the area to be examined, in contrast to B scan, where we place it in the opposite pole. Now there are three sections which it basically gives. One is the transverse section, where it gives you images of 6 clock hours. One is the longitudinal, where it gives you a single scan image, and one is the axial scan. Now this axial can be a vertical and a horizontal. When it is a vertical, you place that white mark which you have seen there superiorly. And when it is horizontal, you place it nasally. So that is the catch for UBM. Only if you know the probe orientation, you are going to catch the images correctly. So now the need of angle evaluation, we already know that PACG is leading cause of blindness, but when it comes to the blindness as compared to open angle glaucoma, it is going to cause much greater blindness as compared to glaucoma. Now this is again an important thing. We know open angle, closed angle, at your stage you know everything. But what about beyond closed angle? There is a component in closed angle that is known as a plateau iris configuration, which is really important and needs to be delineated and to specifically treated. Because again, even if you have seen that the angle is closed and you have done a PI, and the PI is patent, but still your pressures are not coming down, that means go back, do the gonioscopy again. And if you've got the, I can say, UBM at your places, you can go ahead and do the UBM. So let's see the structures both way, and I'm just going to take 3 small cases which will help you that how UBM and gonioscopy, they need to be done hand in hand. Neither can be done alone, and you cannot say ki this is done, this is not done. You have to do hand in hand. But gonioscopy is the most important thing. So now here this is a gonioscopy image where you can see the angle structures. See the angle structures. Here when we start, the TM, the scleral spur, the ciliary body, and the iris. So these are the things when you see gonioscopically. And when it comes to UBM, see it is already highlighted here. And when you do the UBM or see the UBM, no, the most important thing is what? To identify the scleral spur. Because when you identify the scleral spur, this is a landmark in a UBM. From here only all the objective assessments, whatever distances we have seen, no, it is calculated. So identifying the scleral spur is really important when it comes to the UBM imaging. So now talking about the different angle closure, where a case was there with a patent PI in the left eye, and the diagnosis was made like status post-acute angle closures, pressures were normal, but when the gonioscopy was done, after performing a PI, that too was visible patent, in the left eye you see it's not opening. It's again quadrant 0 in all the quadrants. So there was something else which was working, though the pressures were under control, but still a UBM was done. Now when you do the UBM, you see the features in the UBM, what is happening. You see that there is obliteration of the sulcus, the anterior rotation of the ciliary body, obliteration of the sulcus, and a kind of flattening of the iris surface. In this picture, it is much more clearer. So this is what? This is what it could be. I have already mentioned. Plateau iris. Plateau iris. Whenever on a UBM you see this kind of obliteration of the ciliary sulcus with a flat iris configuration, you go ahead and make a diagnosis of plateau iris. Now I have put this figure just to show you the difference between a UBM and a ASOCT. ASOCT cannot penetrate beyond the iris, but UBM especially does. So whenever you think that any pathology is there which is lying behind the iris, you go as a correct choice for being the UBM. Now what do you see in gonioscopy? See this pattern? Can you see this? One hump and the other hump. So a double hump pattern is seen on the gonioscopic image. It's not there, sir. It's not there. So this all now, I will just run through a little bit fast because time is going to get over. So now the case 2 we are talking about. Again, you see that gonioscopically, it's okay. That laser pointer. So what you can do is that here, this was a gonioscopic image, and when the slit lamp examination was done, a bumpy pattern of the iris was seen. And the bumpy pattern was iris was delineated to have these kind of structures lying somewhere in the ciliary body. You can see those cystic spaces are there. So this was a pseudo plateau iris. Something is beneath the iris. It is pushing, but actually it's not the ciliary body, it's a cyst. So it's a pseudo plateau iris syndrome. Now talking about this very important thing which happens in, I can say, the post-glaucoma surgeries, especially when you are dealing with shallow eyes. Now right eye you see trabeculectomy has been done, and in the left eye you see that a patent PI is there. Though the AC looks to be a little shallower in both the eyes. So now we went ahead and did a slit lamp examination where we saw the central AC depth in the right eye, and in the left eye you see it's totally gone. And the right eye, in the right eye it's totally gone in the central area, and in the peripheral area also it's totally opposed. And when you see the left eye, you see little bit is there in the peripheral area, and also in the central area you can at least some millimeter you can make out. So again something was done, gonioscopy. Saw totally closed angle. This is a 4-mirror image. So totally closed angle all around. And when the UBM was done, if you see clearly here, there is a iris corneal touch, iridocorneal touch is there. It's totally rotation of the ciliary body anteriorly. Forget about the obscuring of the ciliary sulcus. It's totally touching the cornea. And when you see here in this left eye, what I was talking about, a flat surface, obliteration. So now a diagnosis, what do you make in your mind? That's malignant glaucoma in the right eye, and in the left eye it was a plateau iris. And plateau iris eyes are the eyes which are more prone to go into malignant glaucoma. Now this is an eye where you can think of what? Pigment dispersion. See the hyperpigmentation of the angle. So the TM, can you see that? Going up to +4.5. So you have to make a diagnosis, and this is how the UBM helps us in evaluating the distance, because these are the eyes. Can you see that concave peripheral pattern of the iris? And these are the eyes which might benefit with PI, though the role is debatable. Not talking of the nenophthalmic eyes, because you know that the prophylactic sclerotomies are important in these eyes, where you see here, there is a supraciliary effusion. Here is a sclera, and here you see ciliary body. You see there is a supraciliary effusion. If you see this, definitely you are going for a prophylactic sclerotomy in your eyes when you are planning for any kind of surgeries in these eyes. Now this is again, I can say, opaque cornea, showing you this kind of image. Trauma could be manifesting in this way or could be this way. Any difference? These two are traumatic eyes, but this is having a high IOP and this is having a low IOP. Can you see here something? It's a cleft. It's an angle recession, the broadening of the ciliary body, but here there is no broadening, but still it is a traumatic eye and the patient is presented with low IOP. And low IOP but no RD. So that means angle is having a cleft. When you go ahead and did the UBM, you see, there is separation of that ciliary body from that, creating a cleft. So now UBM, you know how helpful it is going to be in making the diagnosis. Congenital glaucoma, we know that it is helpful because majority of the congenital glaucomas are presenting with the opaque corneas. This is very important because these aniridic eyes, they present with Wilms tumors. So these are the life-threatening conditions and they present with opaque corneas. Now post-glaucoma surgeries, I'm done, I'm just winding up. So with that, we talk about the limitations. We know that the gonioscopy needs to be done in a, lighting condition needs to be proper. UBM can be done without that. But yes, to conclude, I can say that they are friends forever. And your best friend in your glaucoma clinic is gonioscopy. Thank you very much.
Thank you, Shweta, for your wonderful lecture and also the wonderful collection of UBM pictures. Wonderful, actually. Thank you. Any questions to Dr. Shweta? She's not going to go away. She's going to be here. So next is, I'll just talk on the visual fields.
Yes, sir. So how do you do, like you start your gonioscopies with your 2 mirrors or 4 mirrors? To start with, go with 2 mirrors. Because 4 mirrors, no, they take a lot of manipulation. And whenever you see, you put the important point in 4 mirrors is that no gonio gel is required. So it is not cumbersome for you and neither for the patient. But start with 2 mirrors. Once you start identifying the angle structures, no, and your hand stability comes, then you go ahead with the 4 mirrors. So this is the take for gonioscopy to start.